consultant pediatric endocrinologist at Royal London Children's Hospital, and my special interest is in managing children with glucose disorders. Next slide, please. Next slide. I can't see the slide. So this is my disclosure, and as I said, I've got interest in glucose disorders. Next slide, please. Next. So this is just a quick overview of what I'm going to talk about. First of all, I'll mention about hypoglycemia and what's normal blood glucose range, how do we make diagnosis and clues to make diagnosis, and then I'm going to talk about one of the causes for recurrent hypoglycemia, that is, what is the biochemical mechanism of insulin secretion, the genetic basis, and diagnosis and management. Next slide. So, when we talk about what is hypoglycemia and what is a normal blood glucose range in children, it actually varies. And interestingly, whenever we kind of go through, even in the same department, sometimes we do see that actually people take as different ranges as normal blood glucose in children. And also there have been numerous publications over the last 30 years as, what do we define a normal blood glucose range, either in a neonate or as well as in a child. Next. And what we have to remember is at the moment there is no universally accepted definition of hypoglycemia, which will determine absolute clinical risk or predict sequelae. So we always have to remember that the plasma blood glucose concentration, it must be evaluated in association with the presence of risk factors, the clinical state of the baby or child, and the intermediary metabolites and alternative fuels. And we have to think about an individualized approach when we manage children with hypoglycemia. Next. And for hyperinsulinism, which is a condition that is hypoketotic hypoglycemia, in the UK and EU, we take 3.5 millimoles per liter as a cutoff for management. Next. So there was a publication from Pediatric Endocrine Society about evaluating and managing children with persistent hypoglycemia. And what it defined as that for those neonates with a suspected congenital hypoglycemia disorder, or older infants or children, then they recommended to have a blood glucose concentration more than 3.9 millimoles per liter. However, for high-risk neonates without a suspected congenital hypoglycemia disorder, it was suggested that to take cutoff of more than 2.8 millimoles per liter in the first 48 hours, and then more than 3.3 in after 48 hours of life. Next. And this is one of the articles that was published and actually did come out of the Bart's Health NHS Trust about looking at claims that had been in the last 10 years due to neonatal hypoglycemia. And it was reported that NHS trusts have paid out £162 million in 10-year period due to 25 claims that were related to hypoglycemic brain injury. Next. So when we talk about signs and symptoms, what we have to remember is that not all babies or children will have symptoms of hypoglycemia, and the reason is because if they do have recurrent or persistent hypoglycemia, their brain is used to work on a function at a low blood glucose levels. So we have to always remember that they may have some signs and symptoms of hypoglycemia, but sometimes they may not have it. Also, we have to remember whether they have ketosis, ketotic hypoglycemia or non-ketotic hypoglycemia. So they may have also got symptoms of ketosis where they are mounting high amount of ketones. And it is really important for us to know, or obviously they are vague symptoms, but it's very important as a healthcare professional for us to know, as well as to inform families about those symptoms. And because it's a medical emergency, so obviously if they do have symptoms, it's important that they actually recognize those and treat those and promptly manage it so that you actually actually avoid any implications of the hypoglycemic brain injury. Also, it is important to investigate. So if they have recurrent hypoglycemia, we investigate them. And now, and this has got implications as both in the short term as well as long term outcome. Next. So when we talk about signs and symptoms, we obviously look at, if they have any other etiology. So for example, if they've got unwell with diarrhea, vomiting, fever, we also have to think about some of the other signs, which is, if they are syndromic. So those children who may have syndromic features, or they may have underlying syndromes, and there are several conditions that has already been reported to cause hypoglycemia, i.e. Sinani-Lenz syndrome, Kabuki syndrome, Costello syndrome, Down syndrome, Russell-Silver syndrome. So you have to think about that when you do see children with this syndromic conditions, and if they have any symptoms suggestive of hypoglycemia, then maybe think about investigating them. There can also be age dependent. So obviously, in babies, there will be some different symptoms compared to in older children. And also, as I mentioned, that depending on the frequency or how frequent they have hypoglycemia, their signs or symptoms may vary. Next paragraph. Next slide, sorry. So in terms of diagnosis, so most important thing is that obviously when a baby has presented with persistent hypoglycemia, sometimes we suggest that, in a newborn baby, you always need to stabilize them, and in terms of blood glucose levels, and then you look at whether they have persistent hypoglycemia after 48 hours of life, and determine the cause. And this was actually suggested from the Pediatric Endocrine Society guidelines. And it is really important to get the critical blood samples, which is at the time of hypoglycemia screen. Sometimes, we need to have a central venous access device, especially for administering high glucose concentration, but also to obtain crucial blood samples. So just to kind of think about making sure that we take all the critical samples at the time of hypoglycemia. Next paragraph, next slide. So this is one of the, I'm just sharing a protocol which we have here as endocrine diagnostic fast. Now, obviously, this is in an older child. So depending on, what is the age of the child, we decide the fasting time. And then based on the fasting time, we then make sure that they get all the blood samples taken. So sometimes we need to put a cannula prior to the fasting test. And we then have a list of blood tests that needs to be taken either when they are hypoglycemic, so when they drop the blood glucose during fasting, when they're having a fast test, or at the end of the fast, which is depending on the age, we will decide the duration of the fasting test. Next slide. So it is really important to get a diagnostic test to determine the cause of hypoglycemia. So the preparation is extremely crucial. So whenever we are looking at fasting tests in either babies or in older child, it's important that we get everything ready, and and labels, and getting all the blood bottles ready. Now, if they are on IV fluids, sometimes we have to wean fluids slowly to see and see whether they go hypoglycemic. So you titrate the infusion. So this is especially in babies. You would do titration every 15 minutes and checking blood glucose every 15 minutes to make sure that they don't go hypoglycemic suddenly. Also, as soon as you get blood glucose below 3, you take the hyposcreen samples, and then put the fluids back up onto the normal rate, which what the baby was on. Then the second thing would be is obviously making sure we get all the urine samples also, which is being taken at the time when the baby is hypoglycemic. But more importantly is to remember that you take a heel prick sample or a peripheral sample, which for laboratory glucose, and not from the line which has been used to give IV fluids, because otherwise it will give you spurious results. We obviously make sure we correct the hypoglycemia with the IV fluid 10% glucose bolus, and then we continue monitoring blood glucose levels until we get all the blood results back. Next slide. This is a long list of causes for hypoglycemia in children, and I would, kind of, when just go through as in general, which is ketotic hypoglycemia and non-ketotic or hypoketotic hypoglycemia. And in one of the next slides I will show you a flow chart as how do we determine those ketotic and hypoketotic or non-ketotic hypoglycemia. So when we talk about idiopathic ketotic hypoglycemia, recently there have been some genetic mutation that has been reported. In hyperinsulinism and fatty acid oxidation disorder, they are mainly hypoketotic or non-ketotic hypoglycemia, where you would not see much of ketones at the time of hypoglycemia. And we talk about hyperinsulinism, they can either be transient, especially in newborn babies, or they can be genetically driven. And there are several genetics that has been reported that can cause congenital form of hyperinsulinism. There are also other causes in terms of other endocrine causes and metabolic causes. Mainly from endocrine causes, what we would look at is growth hormone deficiency or adrenal insufficiency. And there are several other metabolic disorders too that causes hypoglycemia in children. Next, please. So this is a flowchart which I was just talking about. So when we look at or when we interpret the hypoglycemia screen, when a child presents with hypoglycemia, you obviously make sure you take all the blood samples, but more importantly, look at what is ketones. So this BOHB is beta hydroxybutyrate, bicarb, lactate, and free fatty acids. Now, when we talk about a condition which is hypoketotic hypoglycemia. So when you look at acidosis, mainly when there is no acidosis, you look at what is the ketones and free fatty acids. So if the free fatty acids and ketones are low, so that means you've got low ketones, low fatty acids at that time of hypoglycemia, then you in particular think about hyperinsulinism. However, there are also conditions like hypopituitarism in newborns that has been reported to cause hypoketotic hypofatty acidemic hypoglycemia. However, if you have got low ketones but raised fatty acids, and that's where you think about fatty acid oxidation disorder. So as I was mentioning that you've got hypoketotic hypoglycemia, in which you've got low fatty acids and low ketones, hyperinsulinism. If you got raised fatty acids but low ketones, then fatty acid oxidation disorder. However, if there's acidosis, then you look at lactate. And obviously, if there's increase in lactate, then there is more of other metabolic conditions, mainly like gluconeogenesis defects. Or increase in ketones, then you think about ketotic hypoglycemia or other endocrine conditions, mainly growth hormone deficiency or cortisol deficiency, which is in older children. So this is just a kind of a brief kind of a flow chart that kind of explains how do we interpret, and hence it is really important to take crucial, critical samples at the time of hypoglycemia in children. Next slide, please. So what are the causes of recurrent hypoglycemia? And that is mainly what we sometimes get worried about. And it's important to look for or investigate those children who have recurrent hypoglycemia. Next slide. So as I was saying that there are several publications recently and how much important it is to actually investigate those group of children to determine the cause. As I was mentioning about idiopathic ketotic hypoglycemia, and there has been fewer newer genes that has been reported that can cause ketotic hypoglycemia in children. Also, there are other syndromic conditions that can cause that, which is Kenani-Lenz syndrome, even isolated growth hormone deficiency, as I was mentioning about in the previous flowchart, that growth hormone deficiency can also cause hypoglycemia. Next paragraph. Next slide, sorry. So just to go on to hyperinsulinic hypoglycemia, which is a condition that causes recurrent hypoglycemia, and it's also important to know because and manage it promptly, because it can cause brain injury because of lack of fatty acids and ketones at the time of hypoglycemia. So this is a really important condition for us to know about and manage it promptly, so that we can avoid brain injury. So it's due to inappropriate secretion of insulin in relation to the blood glucose concentration. It's a cause of recurrent and persistent hypoglycemia in children, and it's a major cause of hypoglycemic brain injury. Next slide, yeah. So I'm just kind of showing.
This conference will now be recorded.
So when we talk about causes of hyperinsulinic hypoglycemia, we are either looking at transient cause, where babies are born to diabetic mom, or when mom is on drugs that is used for diabetes, or had a large IV glucose infusion just prior to delivery, or also babies with intrauterine growth restricted or perinatal asphyxia. Those babies can have transient hyperinsulinic hypoglycemia. Next. And then we are mainly talking about permanent forms, but typically how they would present is that they would have hypoglycemia when they are fasting. So when they are fasting, so especially when you are feeding baby every, say for example, 3 hourly or 4 hourly, and if you do determine any hypoglycemia, that means they are not able to fast as what they should be normally doing, appropriate for their age. And that can also be a cause, and that's where we would say that the baby have got recurrent hypoglycemia, and we need to manage them, sometimes with fluids or sometimes with high calorie fleas. There are other forms of hyperinsulinic hypoglycemia. Mainly, they are postprandial, so they can either be postprandial hyperinsulinic hypoglycemia, which is called as dumping syndrome, and you might come across those children who have had any gastric surgery or gastric banding, and they may have this condition, or it can also be protein induced. So there are genes or mutation that has been reported that can cause protein sensitive hyperinsulinic hypoglycemia. There are also other causes of hypoglycemia, mainly exercise induced, and there is a genetic mutation that has been reported to cause exercise induced hypoglycemia. So the reason I'm giving you this kind of causes is just to kind of keep in mind that history taking is really important, because when you see a child with hypoglycemia, we need to know when the hypoglycemia occurs. Is it due to fasting? Is it just because when they are fasting overnight and they're having hypoglycemia in the morning? Or is it after meals or after exercise? So just to keep in mind that there are genetic mutation that has been reported to cause other forms of hypoglycemia. Next slide. And also syndromes and hyperinsulinism. So when you talk about various syndromes, and now I think the list is becoming bigger and bigger. So when you talk about syndromic conditions, it's there are several syndromes over the years that has been reported to cause hyperinsulinic hypoglycemia. And I would in particular like to highlight Beckwith-Wiedemann syndrome, which is actually which has been reported, and children with this condition can have hypoglycemia, and it's really important to screen them if they have any symptoms of hypoglycemia. There are other syndromes as well, like Mosaic-Turner syndrome, trisomy 13, Kabuki syndrome, Costello syndrome. So there can be several other syndromes that has been reported to cause hyperinsulinic hypoglycemia. Next slide. So when we talk about persistent or congenital hyperinsulinism, where there are genetic mutations which has been known to cause, next slide. So when we talk about referral rates, when we talk about the incidence, in the UK, now the incidence is about 1 in 28,000, and it typically presents in neonatal period or infancy as well as in childhood. So they can present in older children too. The typical biochemical hallmark is hypoketotic, hypofatty acidemic, hyperinsulinic hypoglycemia. What it means is that you've got low ketones, low fatty acids, and detectable insulin at the time of hypoglycemia. So that's why, again, it is very important to take the critical samples at the time of low blood glucose concentration. And it is very heterogeneous in terms of clinical presentation, histology, and molecular biology and genetics. Next slide. So this is a long list of genetic mutations, and the list is keep growing. So actually, when we talk about the genes in that can cause hyperinsulinism, mainly the top two genes, which is the KPCC8 and KCNJ11 genes, they are KATP channel genes that can that accounts for about 50% of genetic mutations in hyperinsulinism. However, this other genes which I was mentioning to you about protein sensitive and exercise induced hyperinsulinism, but this list keeps on growing, and there are newer genes that has been reported in the last few years. I think I can control the slides, Neha. So I think I'm happy to present from here. So when we talk about um, the newer genes which I was mentioning to you about is FOXA2, catenate, EIF2S3, as well as DNAJC3. So these are the newer genes that has been reported in the last few years, and they cause several other features. So we also have to remember that sometimes they can be monogenic. Monogenic means that they have got only genetic mutation, but no other features or no other systemic involvement. But sometimes it can cause other systemic involvement as well. So that's where it is important to remember. And this is where I'm just kind of showing that how different types of children with different conditions present with hypoglycemia or hyperinsulinic hypoglycemia. So when we talk about the first two genes, and that's why I wanted to really mention about these two genes, is because it actually is more commoner, but especially when we talk about genetic mutation in hyperinsulinism, but also it determines the treatment, the investigations and treatment. So mainly these two genes are involved in insulin secretion, which is ABCC8 gene and KCNJ11 gene. And when we talk about the beta cell, so this is a cartoon model that shows the beta cell and the insulin, KTP channels and insulin secretion. So the outer channel here is encoded by ABCC8 gene, and the inner channel is encoded by KCNJ11 gene. So these are the KTP channels that actually, when glucose enters into the cell, so normally what happens is that glucose enters into the beta cell, it undergoes glycolysis, and there's increase in ATP production. As a result, it triggers the KTP channel pathway. It then depolarizes the beta cell membrane and opens up the calcium channels. The calcium then enters into the cell, and that causes insulin secretion from beta cell. So this is when we are eating, when we are having glucose, that's how the insulin is produced. And there are several other mechanisms too that is involved in insulin secretion, but this is one of the commoner mechanism that causes insulin secretion. But just think about when you don't have functioning KTP channels, so especially those babies where they have mutation in those genes, that means the KTP channels are not functioning. What happens is that irrespective of whether baby is being fed or not, the membrane, the beta cell membrane, is continuously depolarized, which keeps the calcium channels open all the time, and that causes unregulated insulin secretion. So when we talk about clinical presentation, generally in babies, you may see symptomatic hypoglycemia, but they can be asymptomatic. So just to keep that in mind, and they usually require large amount of intravenous glucose. And normally we would say that it's 4 to 6 milligrams per kilogram per minute of glucose infusion. But if they do require more than 8 milligrams per kilogram per minute of glucose, then it's likely that they have hyperinsulinism. And they also typically have fasting hypoglycemia. So as I was saying, that if you're feeding baby every 1 hour or 2 hours, and if you keep seeing that they're hypoglycemic before feeds, that means they're not able to fast appropriately. And they can also have postprandial, as I was saying earlier, that they could also have hypoglycemia secondary to feeds, which is either due to dumping syndrome, or they can be protein sensitive hyperinsulinism. So when we talk about diagnosis, it's mainly that they would have high glucose requirements that will be more than 8 milligram per kilogram per minute. You then look at the biochemical results. So they would have low fatty acids, low ketones, and presence of insulin and C-peptide. So detectable insulin and C-peptide at the time of low blood glucose concentration. So that's why it's very important to take the critical samples, and especially looking at those ketones, fatty acids, insulin, and C-peptide. We obviously do other hormone tests as well. So when we go through the hypoglycemia screen, there are several other blood samples and urine samples that will need to be taken at the time of hypoglycemia. And there are other tests that sometimes may be required to actually determine the cause of hypoglycemia. So when I was talking to you about other causes earlier, so mainly sometimes they can be protein sensitive. So you do protein load test, you give protein and then check blood glucose and see what they do. You also do oral glucose tolerance test or mixed meal test to look for if they are sensitive to carbs, or exercise tests, which could be due to exercise induced hypoglycemia. And in terms of management, most important thing is stabilization of the babies or in children. Now, if it is a baby, then sometimes if they are in persistent hypoglycemia in spite of on normal fluids, IV fluids, then sometimes they may need central venous access to give high amount of glucose. In some other babies, we may need to give regular feeds or high calorie feeds. And very importantly, that we have to monitor their blood glucose levels and also the fluid balance, so that we know that the amount of volume of fluid what we're giving is not too much, because there are certain drugs that we use, and especially in this condition, which is the drug that is used commonly is called diazoxide, and that is known to cause fluid retention. So it is really important to manage and monitor fluid balance. So so once you confirm that it is hyperinsulinism in a baby, you would start on a diazoxide. And in babies, we would also give diuretics, especially because diazoxide can cause fluid retention. So you use chlorothiazide or other diuretics like furosemide or spironolactone. There are other drugs that has been reported in the literature that has been useful, like nifedipine. It's a calcium channel blocker. But then if they are not obviously being managed, or if they are difficult, then you use infusions like glucagon and octreotide. And also this infusions are given in specialist centers only, because obviously they need to be monitored for side effects. So if they are not responding to fluids, or they are requiring glucagon or octreotide, then it's best to contact the specialist center. In London, it's Great Ormond Street, and in up north, it's Manchester and Liverpool. So when we talk about diazoxide, we when think about is that diazoxide can cause pulmonary hypertension, as I was earlier saying to you, is about the side effects. So it's very important to think about fluid balance, and and why it is important to monitor fluid balance strictly, because it can cause pulmonary hypertension. And there can be several other issues, especially when we're managing these babies, like sepsis. It's quite stressful for parents. They can have feeding issues, gastroesophageal reflux, or also they can have problems with central lines. So more importantly is that obviously when they are in a specialist center, then if they're not responding to medical therapy, they need to be looked at what could be the reason. And mainly is you think about two main forms, which is diffuse and focal form. So when I was talking to you about the KTP channel mutation, one of the reason is to identify, because they are the ones who may not be responding to medical therapy, and it is important then to really get those to identify whether could it be diffuse disease where the whole of pancreas is affected, or is it a focal where is only a small part of pancreas is affected, whereas the rest of the pancreas is completely normal? Do we
This
prevent
conference will now be recorded.
So how we prevent hypoglycemia in children, and there are certain things that's quite useful to remember, as when the children are on IV fluids, make sure that we look after IV access, because sometimes when their IV cannula is tissued, they can have sudden hypoglycemia, and that's quite natural, because when you stop fluids, they will have rebound hypoglycemia. You also think about making sure you prepare IV fluids early, especially you don't wait for children to be off fluids while you're changing the fluid bag, because otherwise they will have hypoglycemia if they are off fluids for a certain period. Also making sure you attend alarm immediately when the pumps are alarming, also giving medications on time. So there are small things that is less important to keep in mind. As I was saying earlier, that obviously both glucagon and octreotide is given in special centers, but this is just a baby showing how, is having subcutaneous glucagon infusion. So you could use that IV cannula. You could use a subcutaneous IV cannula to put as given as a subcut infusion. And octreotide is another medication that is given either as an infusion, or you can give as injections like 4 times a day. It's like subcutaneous injections, like insulin injection we give. It's given as a subcutaneous injections 4 times a day. And then the next step would be nutrition and feeding. So as I was mentioning, that sometimes they require a large amount of glucose as IV fluids, or through central venous access, or sometimes they need high calorie feeds or added carbohydrates in feeds. And these are some of the, and this is in babies. Obviously, in other children, when they have hypoglycemia, we also give emergency regime. So for when they get diarrhea and vomiting and they have hypoglycemia, we ask parents sometimes to use glucose solution, i.e. either they have Vitajul, which is a glucose powder, and they mix it in milk or water and give it often, or the sachets. They are SOS sachets, which is similar to Diarolite, and you mix 1 sachet in 200 ml of water and give little and often. And this is very used, sometimes helpful in at the time of illness, that they can use. Especially when they're getting hypoglycemia, when they're unwell. So just to conclude, I have got few cases after this, so maybe we can actually have some discussion about that. So when we have persistent or recurrent hypoglycemia in children, we should investigate them and making sure that we take critical samples at the time of hypoglycemia. So preparation is extremely crucial, as it helps us to get the right diagnosis. We also have to remember that hypoglycemia should be treated promptly, as it will have long-term implications in terms of brain development and neurodevelopmental delay. Hyperinsulinism is due to unregulated insulin secretion, and it's a cause of a severe hypoglycemia. And it's important to recognize and treat them properly, as it's known to cause brain damage. And in hyperinsulinism, as I was saying, that it's very important to sometimes differentiate between focal and diffuse, because it actually helps in terms of deciding further treatment. So I would like to just thank all my colleagues in the country, as well as here at BARTS, and other parent support groups. So I've got some cases now. I think maybe.
This conference will now be recorded. This
So
conference will now be recorded.
just to take one. So there is a 4-year-old boy who has been unwell with diarrhea and vomiting for 48 hours, and has not been able to tolerate any oral fluids. And parents noted him to be floppy and lethargic early hours of the morning, and he was then subsequently brought into A&E. So my question is, what are your next steps? So if he's brought into A&E, a 4-year-old with this history, I'm not kind of going into very much of detailed history, but in terms of mainly management, so what will you be doing next? You can put it in the chat. I can read through ABC. Yeah, fair enough. So yeah, I think when you IV access a blood gas, yes. So more importantly is that yes, you would examine, and if you needed, make sure you check blood glucose and yeah, very important, ketones. Well done. So then when we are doing that, you just do blood gas, look for if there's any acidosis, check ketones, check blood glucose levels, and follow ABC. Now you obviously make sure that if the child is hypoglycemic, so now this is a 4-year-old, so what blood glucose would you say you will be taking hypoglycemia screen? Any number? Now again, this will vary from, and department to department. So I think you will have to follow your local policy or local guidelines. But yeah, we generally say anything below 3 if the child is hypoglycemic, anything below 3 would be okay. But just please follow your, if you have any local departmental guidelines, some people would have 2.6 as cutoff, but anything below 3, because if the child is symptomatic and the blood glucose is say 2.9, you can still, you can still take hypoglycemia screen because the child is symptomatic. So that's the next step. So make sure you take the critical samples of hypoglycemia screen. Again, you would have those list of blood tests that needs to be collected, but most important is ketones, fatty acids, insulin, and C-peptide, and then obviously you take cortisol, growth hormone, ammonia, lactate, acyl, carnitine, urine organic acids, and plasma amino acids. Now, some of the tests they suggest that we could take, sorry, I think I'm losing the cursor. Some of the tests you could take as when they are not hypoglycemic, but whatever samples you can take, that will be helpful. So the management point of view, so if you do see that the child is hypoglycemic, you would treat the hypoglycemia and start fluids, IV fluids. Now I wanted to ask if what would be your kind of general management? So if they got diarrhea and vomiting and they are able to tolerate fluids after 6 hours, when would you, or how would you stop fluids, or when would you stop fluids? They started tolerating some fluids now. So just to keep in mind is that when the child is on IV fluids, as I was saying to you earlier, that sometimes when the cannula tissues, you may see rebound hypoglycemia. So if they're all tolerating their oral fluids, just make sure you keep monitor blood glucose and you wean fluids. And sometimes depending on how it obviously depends on the child's clinical condition, but if we feel that child is recovering and you would like to um, stop fluids, then try and monitor blood glucose and wean fluids rather than stopping it completely. And that sometimes works, because we do see that when they are not completely recovered and we stop fluids straight away, then they will have hypoglycemia again. And that becomes bit difficult to manage. And follow-up wise, what will be your advice? And generally, what would you give advice to families? So again, with this group of children where you have, say, if they had a first episode of hypoglycemia, and if they had ketotic hypoglycemia, just have to kind of determine if there's any history of other children suffering from this condition, or if if they have concerns about hypoglycemia symptoms at home but has never been picked up at home. So that would be useful to know, that is this just a one-off episode, or is there been previous episodes, or if there are any signs or symptoms suggestive of hypos at home. And obviously you can give them like an emergency regime, or how do you manage hypoglycemia at home, or you kind of give information about parents just to manage those episodes, and parents to come to hospital again if they have symptoms. And if they have, again, if you are concerned, say for example, while they are admitted and they have recurrent hypoglycemia, then obviously they would need to be in the hospital and may need further investigation before they go home. Or sometimes if they have got better, but we do have concerns about them having probably some underlying disorder, then we sometimes would give a blood glucose meter at home. So if there's any doubt where you feel that there might be some underlying disorder, and might be safe for a child to have monitoring at home, then you may consider giving a glucometer at home, as well as then bringing them in electively for further tests. So yeah, so important to make school aware as well about that, absolutely. So you kind of give a hypoglycemia plan, make sure parents have got all the packs. If they are going to have glucometer, they also need to have glucogel, either glucogel or glucojuice, to manage hypoglycemia. So you make sure that you've given that plan as well, of how you manage the hypo at home. Okay, so the next one, is, so this is a term baby, 39 plus 5 weeks, normal delivery, birth weight of 2.3 kilos. So the birth weight was minus 2.5 ds. So this baby was slightly small for gestational age. This is a primary gravida mom, a normal and had normal antenatal scans and no significant family history. Of note, had a normal examination. On the postnatal ward, the baby was noted to be slightly jittery, so they did a blood glucose levels, and it was 2.1 millimoles per liter. So what would be your next step? So I think every unit would have slightly different policy about managing this babies. Now I think if the reason I've put 2.1 is because I think the BAPM guidelines is similar, where you would kind of keep monitoring, or see, keep an eye. But if this baby is IUGR, if you've got a risk factor and the baby is jittery, so that means the baby is symptomatic at 2.1, then you may want to monitor this baby. And obviously baby's feeding, but you feed the baby, but keep monitoring. Either you can monitor on postnatal ward, which is what most of them would do. But if they then have persistent hypoglycemia, and that's where we're talking about, is cutoff is like it's this first 48 hours of life or after 48 hours of life. But if they have hypoglycemia and baby's being fed, say for example, every 2 hourly, and baby's still having blood glucose of 2.1, 2.2, then that's not normal, because you would expect a term baby to maintain blood glucose levels on normal feeding regime. So obviously, when they have symptoms, just need to keep in mind that they're becoming symptomatic. So that's where the blood glucose levels will need to be looked into. Again, if you treat the hypoglycemia and keep checking pre-feed blood glucose levels, make sure the baby's fed properly, and then when we this is just that case where you've got blood glucose still 2.1 and 2 on 2 hourly feeds, where that itself suggests that this baby is having hypoglycemia, and it's not able to fast as what we would have expected in normal term baby to be at least about 4 hours, I would say, or more. And then you obviously think about doing hyposcreen. So this goes to our earlier question, is whether when do you do hyposcreen? And yes, if they're more than 48 hours, ideally it would be good to do after 48 hours of life. But if you've had taken any samples, when they're hypoglycemia, then it's always important to kind of think about how you interpret those results. um, but if they are having persistent hypoglycemia after 5 or 7 days of life, and you've got this hyposcreen, which then suggests that you've got a low sugars, low blood glucose levels, detectable insulin, fatty acids is low, so non-esterified fatty acids is 0.01, beta hydroxybutyrate is low, which is 0.03. And so you've got low ketones, low fatty acids with detectable insulin at the time of hypoglycemia. So again, this suggests that this baby has got hyperinsulinism and is IUGR baby, not able to fast appropriately. So we have to think about management. So management can either be based on the feeds. You can think about high calorie feeds, depending on what the clinical state and whether the baby is requiring IV fluids. Sometimes we get away with giving high calorie feeds and added carbohydrates in feeds, and sometimes we may have to give diazoxide, which is the first line treatment in this condition, and most of the babies would respond to medication. So again, you think about management, you think about discharge, feeds. So when those babies do go home, and if they do go home on medications, you will have to then think about giving blood glucose monitor to parents. They need to check blood glucose before the feed, and also need to have a hypoglycemia plan. So generally, we would manage these babies once confirmed diagnosis. We would keep blood glucose about 3.5 millimoles per liter. So as I was saying to you earlier, that in this condition, we would recommend to keep blood glucose about 3.5 millimoles per liter, just because of the risk of hypoglycemic brain injury. And this is just a table which I've kept it if it is useful, I've published this in about 4 years ago in Lancet Endocrinology. So again, this just shows about the dose of medications that is used, how they work, and the side effects, and what is important to monitor when they are on these medications. So I'm happy to share this after this.